Vanessa is 45 years of age and has stage 4 uterine serous carcinoma. Her BMI is 36 kilograms per meter squared. Which molecular test or tests would be most appropriate to inform the choice of therapy for her? Number 1, estrogen receptor, progesterone receptor, and HER2. Number 2, let's talk a little bit about what we know about the molecular classification of endometrial cancer. These are data from the elegant studies that were done by the Cancer Genome Atlas that really determined and the loss of that protein is consistent with screening in endometrial cancer. So let's begin with a quick question. Vanessa is 45 years of age and has. Let's talk a little bit about what we know about the molecular classification of endometrial cancer. These are data from the elegant studies that were done by the Cancer Genome Atlas that really determined that all endometrial cancers are not created equal. And in fact, there are 4 major subtypes based on molecular testing that can be done. The first is the so-called ultramutated or POLE subtype. And in those, we see POLE mutations with 100 to 500 mutations per megabase. It's typically, histology-wise, we see endometrioid type, and they can have P10 mutations. The next group of so-called hot tumors is the hypermutated group, which are often characterized by microsatellite instability and aberrations in MLH1. This group you can see 10 to 20 mutations per megabase. Again, majority are endometrioid type, but can be mixed grade, and we often see P10 mutations in this subtype. The third group is all the way on the right, and that's the group of copy number high. Now, this group has high levels of copy number aberrations, only about 2 to 3 mutations per megabase, and is characterized by high-grade tumors and common TP53 mutations. And then finally, our copy number low. Again, only 2 to 3 mutations per megabase, but they're typically endometrioid histology, early grade, and can be characterized by P10 and beta-catenin mutations. Now, these molecular classifications from the TCGA have been used to potentially clinically divide endometrial cancers. And you can see here in the figure on the right that the classifications really do seem to correlate with clinical outcomes, with those patients with a POLE mutation phenotype doing the best, and those with the P53 aberrant phenotype or copy number high phenotype doing the worst. Now, there have been a couple of different studies that are looking at how we can utilize these molecular strategies to start subtyping these patients and their tumors at the time of diagnosis and treatment. And you can see here one thought process around how to move through is to start with the POLE sequencing and then move on to the immunohistochemistry testing for the mismatch repair proteins to get an idea if the tumor has microsatellite instability high. And then to utilize P53 sequencing or immunohistochemical testing to divide the patients between copy number high and copy number low. Now, again, this has mainly been found to have prognostic value, although there are some early studies ongoing to see if these classifications can be used to direct treatment. We wanted to focus a little bit more detail around those recommendations for molecular testing that can help inform treatment decisions for endometrial cancer in the present day. And the bottom line is really that microsatellite instability testing and looking at mismatch repair proteins is essential to help guide treatment decisions. So there are 2 different options that you can do. The first is to utilize immunohistochemistry to look for protein expression. And specifically, if you see protein loss of any of the mismatch repair proteins, which include MLH1, MSH2, MSH6, and PMS2, the loss of that protein is consistent with the presence of mismatch repair deficiency or microsatellite instability high. Now, I will mention as an aside, when you see these, we do need to evaluate if this patient has Lynch syndrome for all of the genetic implications that might have. And so if you see loss of MSH2, MSH6, or PMS2, that should prompt genetic evaluation immediately. If you see loss of MLH1, you want to first utilize promoter hypermethylation testing to clarify if this is a Lynch syndrome associated aberration or not. And if you do see the presence of MLH promoter hypermethylation, then this is not consistent with a Lynch syndrome. So definitely make sure you get that testing when you see that MLH1 protein loss. So in addition to testing for mismatch repair proteins, it's also really important to check for HER2 in patients with endometrial cancer, and specifically in patients with uterine serous tumors. And what we can find is the presence of HER2 overexpression or gene amplification can be quite common in approximately 30% of endometrial cancer overall. And there have been randomized phase 2 studies that have demonstrated that in patients with either HER2 overexpression or amplification, that the addition of trastuzumab to standard paclitaxel and carboplatin can yield improved progression-free and overall survival. So really important to make sure you're checking that in your patients with uterine serous tumors. Let's talk a little bit about how we can utilize screening for endometrial cancer and really recommendations around screening for endometrial cancer, as well as guidelines on risk and disease prognosis. So the bottom line, there's no recommended screening for endometrial cancer in a standard way. We don't necessarily need to be checking this on our patients every year in the absence of symptoms. But if we do see abnormal bleeding, whether that's postmenopausal bleeding or really heavy bleeding in a woman that is premenopausal, we need to look and make sure that we have ruled out endometrial cancer. And you can do that in a number of different ways, but the best way is an endometrial biopsy. Certainly, a transvaginal ultrasound can be very helpful. And of course, do consider genetic testing if there's a prior family history of endometrial cancer or colorectal cancer. Now, the way we will stratify patients based on risk is really typically related to uterine features. So, what is the histologic type? What is the grade of the cancer? Is there a presence of myometrial invasion? Is there lower lymphovascular space invasion? These things should be looked at across all patients. And we're now working on how we might utilize molecular testing, so outside of those uterine features, to understand risk groups. And as I mentioned before, we're still working out exactly which ones are the best to utilize. But I think most people would agree that at the baseline, looking at mismatch repair protein loss is essential. And then consideration for things like aberrant P53, HER2, ER or PR expression, as well as P10 expression, can be very helpful to have a sense of where this patient's prognosis sits and potentially what treatments might be of best interest for her. Now, when we're talking about screening for endometrial cancer, it's really important to focus specifically again on Black women with postmenopausal bleeding, because there have been studies that have demonstrated, unfortunately, that Black women are less likely to report their postmenopausal bleeding or really abnormal bleeding, and they're less likely to receive guideline concordant care. So what we can see is, if you look at the study that was reported, a high proportion of Black women did not receive guideline concordant care as compared to white women, specifically less reporting of their bleeding, less diagnostic procedures, and overall less guideline concordant care. How can we help women navigate this healthcare system and really address the inaccuracies of U.S. clinical guidelines for the diagnosis of endometrial cancer based on race? So currently, the American College of Obstetrics and Gynecology guidelines recommend an endometrial biopsy for diagnostic confirmation of endometrial cancer only if the endometrial thickness is more than 4 millimeters via transvaginal ultrasound. Well, There have been studies that have indicated that the predicted performance of this threshold using a simulated cohort of US Black women actually found that the sensitivity of this threshold is quite low at 47.5%. The specificity is only 64.9%, yielding a positive predictive value of 13% and a negative predictive value of 91%. And so this would suggest that more than 50% of missed cases and eightfold higher frequency of false negative results for Black women versus the general population. So these guidelines are not ideal for Black women with the potential for endometrial cancer. There are some opportunities that we have to really expand access to care through technology. And this includes novel early detection strategies that are designed to reduce health disparities in endometrial screening. And this includes things like smartphone apps, artificial intelligence, health promotion outside of the physical clinic. And they all hold certain promise for early endometrial cancer detection. And with that early detection, we hope that that would yield improvement in morbidity and mortality. So, for example, here's a potential future approach that could really help us risk stratify patients and ensure they get diagnosed early. So, let's say we had an app utilizing artificial intelligence, and starting at 40 years of age, we have the patient self report their vaginal bleeding, menopausal symptoms, and obesity score, whether they've had a prior endometrial biopsy, and really their family history. At that point, based on these results, if the AI determines that this patient is at high risk for endometrial cancer, the app recommends self-collection of different potential markers, such as adipokines or insulin sensitivity, genetics, inflammation, and vaginal molecular testing, all using a tampon, something that she could do at home. Now, if the patient was found to be low risk, they would just be reassessed yearly. In addition, we could see low-risk self-collection of things like diet, exercise, hormonal therapy, metformin, and this would allow for a yearly assessment, hopefully help keep that risk low. Conversely, in those patients found at high risk, we could see that they would be encouraged to see their health professional right away, obtain a biopsy, learn about behavior modifications which might help reduce their risk, and even consider surgery if that was an appropriate option for them. So let's transition back to our question. Again, Vanessa was a 45-year-old patient with a stage 4 uterine serous carcinoma, BMI of 36 kilograms per meter squared. Now, based on the previous discussion, which molecular tests would be most appropriate to inform the choice of therapy for her? Number 1, estrogen receptor, progesterone receptor, and HER2. Number 2, estrogen receptor, progesterone receptor, and mismatch repair proteins by immunohistochemistry. Number 3, HER2 and mismatch repair proteins by immunohistochemistry. Number 4, broad panel testing. Or number 5, uncertain.